She had been on the ward for 19 days when it happened. 19 days of being called rookie by people who had never seen what she had seen, never been where she had been, never made the kinds of decisions she had made in the dark with no backup and no margin. They handed her the lightest assignments. They corrected her charting in front of patients. They laughed once not quietly enough about how the new girl jumped at loud sounds. She did not correct them. She did not explain. She folded the laughter into whatever place she kept things that did not deserve her energy, and she went back to work. Then the doors came off their hinges, and everything that had been hidden, everything she had never offered, never announced, never performed, walked into the room on its own. Naval Hospital Camp Lejeune was not a quiet place, but it had a particular rhythm that you either learned or you didn't. I had been a senior corpsman there for going on 6 years, which meant I had seen the rhythm absorb a lot of different people in a lot of different ways. Some people caught it fast, found their footing, figured out the dynamics, became part of the institutional body without losing themselves. Others never quite synced. They produced friction without meaning to, and the friction wore on them and on the people around them, and eventually they transferred or washed out or simply endured until the assignment ended. I was neither frictionless nor failing. I occupied the honest middle of a long career in military medicine, competent, consistent, trusted by the people who worked alongside me, invisible to the people above me in the ways that tend to accumulate over 6 years without major incident or distinction. I was good at my job. I had stopped expecting that to translate into anything beyond the work itself, which is a kind of peace that takes time to arrive at. The ward I worked on handled post-surgical recovery and complex wound care, which meant our patients were almost always Marines, young men and occasionally women coming back from places where the work of healing was harder than the work of being wounded, which is saying something. You developed a particular relationship with those patients over time. Not sentimental, not pitying. They did not want pity and would have made that clear, but a kind of informed respect built from the daily proximity to what they had been through. My colleagues on the ward were people I had known long enough that the professional relationships had developed their own texture. Sergeant First Class Dibble ran the ward with the particular authority of someone who had been doing it for 12 years and had outlasted 3 hospital commanders. He was not warm, but he was fair in the way that fairness is actually useful, consistent, unapologetic, applied equally regardless of rank or origin. Lieutenant Harmon was the senior nursing officer, an Annapolis graduate who had chosen medicine over surface warfare and had never seemed entirely certain the choice had been right. He was skilled and somewhat brittle, and managed his brittleness by maintaining absolute control over the hierarchy of the ward. Below him, 5 nurses and 4 corpsmen. I was the longest tenured of the corpsmen. The ward had its own social life, which is inevitable in any closed institutional environment. We ate together when schedules allowed, covered for each other when they didn't, and maintained the particular combination of professional formality and personal familiarity that military medical environments develop. It was not a family, as people sometimes say about close working groups. It was something more functional and less romantic than that, a unit, in the specific sense, with shared standards and shared accountability and the kind of trust that is built on reliability rather than affection. I tell you this because the environment matters for what happened, because what happened did not occur in a vacuum. It occurred inside a specific culture, with specific power lines and specific habits of perception, and understanding those habits is the only way to understand how so many of us could have had her in front of us every day and not seen what we were looking at. Her name was Lieutenant Junior Grade Mara Osai. She arrived on a Thursday morning in January, transferred from what her paperwork described as a previous medical assignment, details limited. She was 29 years old. She was quiet in a way that read, in this particular environment, as uncertainty. She was black, which in a ward where the senior medical staff was almost entirely white and male, was another variable in a room that had already made its assessment before she finished signing in. Lieutenant Harmon gave her the orientation. I was nearby, organizing supply manifests, and I watched it without meaning to. He walked her through the ward with the particular efficiency of someone who had given the same tour enough times to have stopped seeing what he was showing. She listened and asked no questions. He appeared to find this confirmatory of something he had already decided. She was assigned to the lowest acuity patients. That was the standard for new arrivals, I told myself. That was just the process. I believed that at the time. I am less certain I still do. The first thing that registered, not as alarm, not as anything I named at the time, but as a small catch in my understanding of how things fit together, was how she moved. Not dramatically, not in a way that announced itself. But I had been in military medicine long enough to have developed a baseline for how people moved in a ward environment, and she did not move to that baseline. She moved with a compression that was different, an economy. The way she turned when something happened behind her, not the startled turn of the inexperienced, but a controlled, weighted pivot that placed her body in relation to the new stimulus with a precision that was automatic. The kind of automatic that training produces over a long time until the response is faster than the decision. I noticed it and did not examine it. There was too much work, and the observation had no category yet. The second thing was her hands. In complex wound care, hands tell you everything about a practitioner's experience level. New nurses have careful hands, deliberate, slightly slow, consulting their knowledge as they work rather than moving from the knowledge directly. Experienced nurses have fluid hands. Osa had something else. She had hands that moved with the specific, pressured efficiency of someone who had dressed wounds in conditions where speed and accuracy were equally non-negotiable. She was, in the low acuity work Harmon had assigned her, visibly underutilized, the way a tool built for one purpose looks when it is being used for another. Dibble noticed the hands before I said anything. He did not say it directly, but I caught him watching her work on her fourth day, and his expression had the particular quality of someone recalculating an estimate. He moved on. He did not revisit it. The comment that crystallized everything uncomfortable about those early weeks came from Lieutenant Harmon on the sixth day. He had reviewed her charting from the previous night and found a notation he considered overly detailed. She had flagged a subtle change in a patient's wound presentation that he felt was within normal variance and did not require documentation at the level she had applied. He told her this at the nursing station, not privately, in the presence of 2 other nurses and myself. He said the notation was excessive and reflected an overcorrection common in personnel adjusting from lower acuity settings. He said it was important to calibrate documentation to the ward standard rather than importing habits from wherever she had come from. He said this last part with a particular emphasis that communicated, without stating, that wherever she had come from was assumed to be less rigorous than here. She listened to all of this. She said without visible affect that she understood and that she would adjust her documentation accordingly. She did not say that the change she had flagged, the subtle wound presentation shift, had 2 days later resolved into a mild infection that required antibiotic intervention. She did not point this out when the infection was caught. She continued working at the documentation level Harmon had specified and said nothing further about the earlier notation. I knew. I had been present for both moments, and I could trace the line between them. I said nothing to Harmon about it. I told myself it had resolved without consequence, and that raising it would create friction without improving anything. The other nurses had also noticed the infection outcome. One of them, corpsman Layla Chen, who had been on the ward for 2 years and had a quiet, observant quality I had always respected, looked at me across the nursing station the morning the antibiotic order went in, and the look said something neither of us was prepared to say aloud yet. We let it pass. What I cannot fully account for is the social weight of those weeks. The jokes were not loud or cruel in the overt sense. They were the kind of jokes that require a certain audience and a certain unspoken agreement about who the subject is. Lieutenant Harmon did not participate in them directly, but his dismissiveness created the permission structure, and the younger nurses occupied that structure in the way that younger people often occupy the permission given to them by authority, without fully examining what they are participating in. Os did not react. Day by day, she came in, did her work, and gave them nothing to grip. I watched this and did not intervene. That is the fact of it. There are moments in any prolonged situation where the accumulated evidence crosses a threshold, where the individual observations, each of which had been isolated and assigned a mundane explanation, suddenly refuse to stay isolated. They arrange themselves, and the arrangement produces a picture you cannot unsort once you have seen it. For me, that moment came in the 3rd week. A patient had been brought back to the ward after a complication in post-operative recovery, a Marine Staff Sergeant, mid-30s, abdominal surgery following a training accident. He had been restless and running a low fever since being returned, which was being monitored but had not escalated to intervention. I was on overnight when his status changed. I was across the ward when I heard the shift in his vital monitor. I moved toward his room and arrived to find Osai already there. She had been closer, had reached him first, and was assessing with her hands and eyes in the particular rapid sequence I had watched her use before. Not the checklist sequence. The field sequence. The one you use when you need to know now and cannot wait for the monitor to confirm. She told me without looking up that his abdomen was presenting signs consistent with early peritoneal irritation and that she was concerned about a post-surgical leak. She said his blood pressure drop was subtle but directional. She said she wanted a surgical consult in the next 15 minutes. I looked at his chart. His numbers were borderline, concerning enough to watch, ambiguous enough to justify waiting. In the standard ward logic, waiting was the reasonable call. I looked at her face. She was not uncertain. She was not performing urgency. She had the expression of someone who had made this specific calculation before and knew what the cost of being wrong in the direction of delay looked like. I paged the surgical consult. The surgeon arrived annoyed, reviewed the patient, began arguing that the presentation was within watchable range. Osai said, politely and without raising her voice, that given the trajectory of the blood pressure reading over the preceding 40 minutes and the specific presentation of the abdominal wall, her assessment was that intervention should not wait for further confirmation. She said it the way someone says a thing they are not going to unsay. The surgeon looked at her for a moment, assessed her rank, her newness, the word rookie that had attached itself to her in the ward's informal vocabulary, and appeared to reach a decision based on those variables rather than her argument. He ordered continued monitoring. He left. She stood at the patient's bedside for the next 35 minutes, monitoring manually between the machine readings. At the 40-minute mark, the patient's pressure dropped. At 43 minutes, the surgeon was recalled urgently. At 47 minutes, the patient was in emergency surgery for a post-surgical anastomotic leak. He survived. The surgeon's notes attributed the catch to the monitoring protocol. They did not mention who had initiated the request or what the argument had cost to make. The next morning, I found Osai at the supply station before the shift started. I stood beside her for a moment and said without preface that she had been right and that it had mattered. She did not look up from the supply count. She said she was aware and that she appreciated me saying so. I asked, more directly than I had asked anything before, where she had come from before this assignment, what her background was before nursing. She counted a row of dressings. She said her prior assignment was a matter of record and that I was welcome to review her file if I had access. I said I was asking her directly. She looked at me then. Her eyes did the thing I had noticed before, that brief, assessing sweep that was not social but tactical. She held my gaze for a moment, and then she said that the things she had done before were not currently relevant to the work in front of her, and that she was focused on the work in front of her. She went back to the count. I stood there for a moment longer than was natural. Then I left. File was accessible through the ward's personnel system at a basic level. I looked at it that afternoon. What I found was a service entry date, nursing qualification date, assignment history that was vague in its location descriptions, and a note that certain sections were restricted pending clearance verification. The years between entry and nursing qualification were 4 years labeled as prior service. No branch notation in the accessible section. I closed the file. I thought about her hands. I made the mistake, on a Thursday afternoon in the 3rd week, of raising it with Lieutenant Harmon. I framed it carefully. I said I had observed some aspects of Lieutenant Osai's clinical approach that seemed to reflect a level of experience that went beyond what her file indicated, and that I thought it might be worth understanding her background more fully. I said it in the neutral language I had learned over 6 years was the only language that moved through Harmon without triggering his defensive architecture. It did not work. He listened with the expression he used when he had determined the conclusion before the evidence was complete. Then he said that it was not uncommon for personnel arriving from certain prior assignments to develop compensatory behaviors that resembled confidence, that the appearance of experience was not the same as its possession, and that the ward had standards precisely to calibrate the difference. He said that my observation reflected a generosity of interpretation that was understandable but probably misplaced. He said she needed time to find her level. I said specifically that the anastomotic leak catch had been hers, that she had identified it, requested the consult, and maintained manual monitoring until the situation confirmed her assessment. He said that the monitoring protocol had functioned as designed and that the outcome reflected the ward system rather than any individual's exceptional intervention. I looked at him for a moment. There was a particular smoothness to the way he said it, the way a person speaks when they have already decided that a fact is inconvenient and have located the language to make it administrative rather than human. I said nothing further. I thanked him for his time. I left. What happened after that conversation was subtler than punishment and more corrosive than silence. I began to be corrected in team briefings in ways that were slightly more frequent than before, nothing dramatic, nothing provable, but directional. My supply reports were reviewed with an additional layer of scrutiny that had not previously been applied. Harmon mentioned once in a group setting that consistent clinical practice required all personnel to work within the established role structure, and that informal assessments shared outside proper channels created liability concerns. He did not look at me when he said it. He did not need to. Dibble came to me privately that week. He said quietly that whatever I had said to Harmon about the new nurse had registered in a way that would be worth managing carefully. He said he wasn't telling me I was wrong. He said he was telling me the landscape. I understood what he was giving me. He was handing me information at personal cost, wrapping it in caution so that neither of us had to name what it was. Meanwhile, the attitude toward OSI among the junior nursing staff had curdled in a specific way. The jokes had not increased, but their texture had changed. They had moved from the casual dismissal of the new and uncertain to something more targeted. One of the nurses, a young man named Specialist Cruz who had been on the ward for 8 months and had appointed himself the social arbiter of new arrivals, had begun referring to her in informal settings as the candidate. As in someone still being evaluated. As in not yet confirmed. He said it with the lightness of someone who is not aware they are doing something. That unawareness was its own kind of indictment. Osai, as far as I could tell, did not hear it. Or if she heard it, she allocated it to the same place she had allocated everything else, a place beyond visible reaction, accessible only to her. Chen came to me after a shift and said, low and precise, that she was tired of watching it. I asked her what she was going to do. She said she didn't know what she could do that wouldn't cost her more than she had to spend. We sat with that for a moment, both of us, in the specific discomfort of people who know the right thing and understand the cost of it. We did not arrive at a plan. The shift ended. We went home. I drove back to my quarters that night and sat in the parking lot for longer than I needed to. I thought about the anastomotic leak. I thought about what Harmon had said, that the system had functioned as designed. I thought about what that meant as a description of what had actually happened in that room, about the distance between language that protects a hierarchy and language that tells the truth about who did what and why it mattered. The distance was large. I had known it was large for a long time, knowing it had not moved me to do anything about it. I went inside. I went to sleep. The next week arrived, and then the week after that, and then the morning the situation ended the way all suppressed truths eventually end, by forcing itself into the open. It started with a records discrepancy flag. The hospital's administrative office ran periodic credential verification reviews for all clinical personnel, and in the 4th week of Osai's assignment, her verification came back with a flag. Not a disqualifying one, not a suspension or investigation trigger, but a notation that her prior service record contained restricted sections that had not been cleared through the hospital's standard verification process. The administrative office forwarded the flag to Harmon. Harmon, to his credit in the narrow procedural sense, submitted a clearance request to the appropriate oversight body. The response took 3 days. What came back was not a clearance. It was a referral, which meant the restriction was not standard administrative lag but deliberate, maintained by an office that had the authority to maintain it. Harmon did not tell the ward. He told me because I was the longest tenured corpsman, and he occasionally used me as a sounding board in ways that fell short of genuine consultation. He told me in the tone of someone who finds administrative complexity personally inconvenient. He said there was some bureaucratic irregularity in her prior service record, and that he had escalated it and was waiting for resolution. He said it did not affect her current assignment in any operational sense. I asked him what kind of irregularity. He said the specifics were above his clearance level, above his clearance level. I heard that and did not let the implications surface immediately. I filed it where I had been filing things for 4 weeks and told myself I would examine it later. Chen was the next one to find something. She told me about it without planning to. We were both staying late after a shift, doing the kind of end-of-day administrative work that accumulates in any ward. And she said in a voice that was trying to be casual that she had looked up the personnel classification codes on Osai's file, the ones in the visible section, because she had been curious what the prior service notation referred to. She said one of the codes was not a medical core code. I looked at her. She said she had cross-referenced it. The classification code in the prior service section corresponded to a special operations designation. She said she had double-checked because she thought she had misread it. She had not misread it. We sat with that for a moment. Special operations designation in a prior service record combined with a clearance restriction that exceeded Lieutenant Commander Harmon's access level, combined with 4 unspecified years between service entry and nursing qualification, combined with everything we had both watched over the preceding weeks. The hands, the movement, the anastomotic catch, the way she assessed a room when she entered it. The way she had stood at that patient's bedside for 35 minutes without being asked and without wavering. I said her name, not as a question, as a recognition. Chen looked at the floor. She said she didn't know what to do with it. I said we should tell Dibble. We told Dibble. He listened without interrupting, which was his way, and when we finished he was quiet for longer than was comfortable. Then he said that if what we were describing was accurate, if the classification code and the clearance level and the behavioral indicators pointed to what they appeared to point to, then there were 2 things he was confident about. The first was that Lieutenant Ose had not been assigned to this ward by accident, and that someone above the hospital command level had known what they were placing here. The second was that if that were true, then the way the ward had been treating her for 4 weeks was a problem that went beyond personal dignity or fairness and into something with institutional dimensions that none of us were fully positioned to manage. He said he was going to make a call to the base's personnel security office. He said he would do it through the correct channel, which meant it would be slow and procedural and would probably not produce results in the near term. He said in the meantime we should go about our work. We went about our work. The next morning, Osa came in for her shift the same way she had come in every morning, early, quiet, systematic. She checked the overnight notes, reviewed her patient assignments, began her rounds. Cruz made a comment in the break room that I did not fully hear but whose shape I recognized. 2 of the junior nurses laughed. Osai, whose patient room adjoined the break room and who may or may not have heard, continued her assessment without pause. I stood in the corridor and watched her for a moment and thought about the classification code and about what 4 years in a special operations designation means as a description of a person's actual history. About what that history would feel like to carry into a room where Specialist Cruz was making jokes about whether you had found your level yet. I thought about her face during those jokes, the absence of any visible cost, and I revised my understanding of that absence. It was not imperviousness, it was experience. She had been in rooms before where the people around her did not understand what she was, and she had learned that correcting their understanding was not her job. Her job was to be ready, and she was always ready. Dibble's call to personnel security went into a system that moved at its own pace, which is to say slowly, which is to say that when the doors came off the hinges, it had not yet produced any formal outcome. The attack, when it happened, was not random. That became clear afterward in the forensic reconstruction that these events always undergo. The target was the hospital, specifically the ward section housing high-value patients, of which we had 3 at that time. A Marine general recovering from cardiac surgery, a special operations officer in post-operative recovery from a classified injury, and a senior duty civilian who had been admitted under a non-descriptive cover story that most of the ward staff had accepted without examining. I did not know any of this at the time. What I knew at 0740 on a Tuesday morning was that the power to the main corridor cut, that the emergency lighting activated, and that the sound from the main entrance was not a sound that belonged in a hospital. I was at the nursing station. Osai was in a patient room at the far end of the hall. Chen was at the supply cabinet. Cruz and 2 other nurses were in the break room. Harmon came out of his office and stood in the corridor with the expression of someone whose categories for understanding the situation had not loaded yet. He said something about a power failure. He was still saying it when the doors to the ward came open. There were 4 of them, armed, moving with the coordinated purpose of people who had rehearsed the space. They came in at an angle that cut off the nursing station and the main exit simultaneously, which was tactically deliberate. What happened next I am going to describe as accurately as I can, because accuracy is what it deserves. Osa came out of the patient room at the end of the hall within the first 3 seconds. She had heard the doors, or perhaps she had heard something before the doors, some change in the building's sound signature that the rest of us had not processed, and she came out moving differently than she had moved at any point in the preceding 4 weeks. The compression was gone. She moved with the full economy of someone who had stopped managing herself for an environment that was not built for her. She assessed the situation in the corridor in what I estimate was 2 seconds. 4 armed individuals, their positions, their lines of movement, the locations of the nursing staff and the patients. She read all of it and she moved into it. She did not do anything cinematic. There were no speeches. What she did was move to a position that cut the sight line between the two individuals who had taken the nursing station and the two who were moving toward the patient rooms, and she said, in a voice that was completely steady and had nothing of the ward's register in it, that they needed to stop where they were. The voice alone changed the room. That is the most accurate description I have. It was a command voice, the kind that is not requesting compliance but stating a condition. I had heard that voice in training, deployed from senior officers in high-stress drills. I had not expected to hear it from the woman who had been quietly counting dressings 4 hours ago. 2 of the 4 individuals hesitated. That hesitation was consequential. Dibble had hit the emergency alert from the secondary panel at the moment the doors opened. He had been closer to it and had reacted faster than anyone else. The base security response was inbound from that moment, running on a timer that was still ticking. Osai's job, in the 3.5 minutes that elapsed between the alert and the security response arriving, was to hold the situation. She did this without a weapon, which she did not have, and without backup that was present, which she did not have, and with 4 armed individuals in an enclosed space, using the specific skill set that 4 years of special operations service develops and that no nursing qualification either requires or teaches. She placed herself between the individuals advancing toward the patient rooms and the patients. She held position with the particular stillness of someone who has learned that stillness communicates certainty, and certainty is the one thing that disrupts the confidence of a rehearsed entry. She spoke twice more, both times in the command register. Both times with the same complete absence of fear, or what I would have called absence of fear before I understood that it was not absence of fear, but management of it, practiced down to a level below visible threshold through repetition in conditions far worse than this. The base security team came through the secondary entrance at 3 minutes and 28 seconds. The situation was resolved without a patient being reached. Harmon had been against the wall for the entire duration. His face had the quality of someone who had watched the ground shift beneath a building they had believed was stable. He was not injured. He was not capable of speech for several minutes after security cleared the ward. Cruz was on the floor of the break room where he had stayed from the moment the doors opened. He was also uninjured. Osai was standing at the nursing station when security arrived, her hands visible, her breathing even. She gave a verbal assessment of the situation to the first officer through the door in the language of someone who had done this before, clear, structured, moving from the most critical information to the least without prompting. The officer looked at her. He said involuntarily, "Ma'am, what unit are you with?" She said she was with the nursing staff. He looked at her for another moment and did not say anything else. The lockdown lasted 4 hours, then the interviews. Then the paperwork, because military medicine runs on documentation even in the aftermath of crises. Perhaps especially then, because documentation is the way institutions process what they cannot otherwise integrate. I sat in the secondary conference room and gave my account 3 times to 3 different people at 3 different authority levels, and each time I gave it, the shape of what had happened in that corridor became clearer and also more painful to articulate. Not because it was difficult to describe, because describing it required me to describe the full context, the 4 weeks of context, and the full context was not comfortable to present accurately. The investigative officer in the final session was a woman, a Marine lieutenant colonel, and she had the particular quality of someone who asks questions she already knows the answer to and is determining whether you are going to tell her the truth. She asked me how long Lieutenant Osai had been on the ward. I said 4 weeks. She asked how she had been received. I said the standard reception for a new arrival. She looked at me. She waited. I revised my answer. I said the reception had been consistent with what happens when a ward has a well-established culture and an individual arrives who does not fit the existing social template. She continued to wait. I said the reception had included a pattern of dismissal, from leadership and from staff, that had been casual in tone and consistent in practice, and that had been applied without examination of whether it was deserved. I heard myself say it, and I felt the weight of it land in the room. She asked if I had observed anything in Lieutenant Osai's conduct that had given me reason to question the adequacy of the frame the ward was using for her. I said yes. She asked when I had first observed it. I said the first week. She wrote something. Then she asked what I had done with that observation. I told her. I told her about the conversation with Harmon and what he had said and what I had done after, which was, in the most accurate accounting, nothing that was commensurate with what I had understood. I had told Dibble. Dibble had made a call. The call was in process. And in the meantime, the ward had continued operating exactly as it had operated before, with all the same assumptions and all the same permissions intact. I told her all of this. I did not make it softer than it was. When I was done, she was quiet for a moment. Then she asked one more question. She asked if, in my assessment, the pattern of treatment Lieutenant Osai had received in the 4 weeks before this incident had constituted a professional environment appropriate to her rank and her service history. I said no. She wrote that down also. I went back into the corridor after the session ended, and I stood there in the particular aftermath stillness of a space that has not yet been restored to ordinary function. The supply cabinet was open. The monitoring station had been partly displaced in the response. There was a mark on the wall near the nursing station that had not been there this morning. I thought about the anastomotic leak patient, recovering in his room, who would have died or come close to it without an intervention that the ward's official record attributed to the system functioning as designed. I thought about Harmon saying she needed time to find her level. I thought about Cruz and his word candidate, delivered with the ease of someone who had never been asked to question the authority behind his assessments. I thought about what it would feel like to carry what she carried, the specific history of it, 4 years of operational reality, the weight of what you know you are capable of, and to walk into a room where none of that is visible, and to have the choice between announcing it and simply being it, and to choose simply being it every day, while people around you decide with complete comfort and zero information that you have not yet found your level. That choice was not passive. That was the thing I needed to fully understand, sitting in that corridor. The silence was not absence. It was discipline. The discipline of someone who had been trained not to perform what they were but to enact it quietly, precisely, when it was required. She had enacted it for 4 weeks in the form of clinical catches that were attributed elsewhere. She had enacted it in 35 minutes beside a patient's bed. She had enacted it in 3.5 minutes in a corridor with 4 armed individuals and no backup. And before any of that, every single day, without acknowledgement, without complaint, she had enacted it by continuing to do the work inside a frame that should have broken under the weight of who she actually was. I stayed in the corridor until I heard my name being called for the administrative reset meeting. Then I straightened up and went in. The formal review process moved through the institution over the following 2 weeks with the particular momentum of something that has been given both urgency and authority. The Lieutenant Colonel's office had initiated an incident review that encompassed not only the security event, but the ward's professional environment in the period preceding it. The scope of the review was, by the standards of these processes, broad. Harmon was placed on administrative review. The formal language described it as a review of supervisory practices and personnel integration protocols, which was the institutionally correct framing. What it meant in practice was that his management of the ward, his decisions about role assignment, his responses to clinical observations, his handling of the credential flag, his conduct during the incident itself, was being examined by people who had the authority to determine its consequences. He did not receive those consequences immediately. These processes are slow, as I said, and the military has its own pace for accountability that is distinct from what the word implies in ordinary usage. But the review was real, it was documented, and it would follow him in the ways that documented reviews follow people. Cruz received a formal counseling notation for conduct unbecoming in a professional medical environment. He was also given a mandatory course completion requirement that occupied several of his off-duty periods. He completed it without comment, as far as I know. Whether it changed anything in him, I cannot say. I hope it changed something. I do not know that hope is warranted. Lieutenant Osai's personnel file was updated. The restricted sections were cleared, and the full record was made available within the hospital's system at the appropriate clearance level. What the full record showed 4 years of special operations service, 2 combat deployments, a classified commendation that was listed without detail, and the nursing qualification she had added to her already substantial background was now visible to anyone authorized to see it. The administrative office sent a notification to the ward. Harmon received it while he was on administrative review. I do not know how he processed it. I did not ask. Dibble came to me after the review concluded its preliminary phase and said, with the straight-line honesty he applied to everything, that he was sorry he had framed his advice to me as a question of landscape rather than a question of what was right. He said he had known the distinction and had chosen the safer framing, and that the choice had contributed to a ward environment that he was not willing to describe as acceptable in retrospect. He said it once. He did not repeat it or elaborate. He went back to his work. Chen was asked to provide a formal account of her observations during the 4 weeks, and she did, thoroughly, accurately, without softening. She told me afterward that it had been uncomfortable to put it in writing, that seeing it laid out in formal language made it harder to categorize as simply how things go. She said she thought she had told herself for too long that awareness was the same as action, and that the review had clarified the difference. Osai returned to the ward on the 8th day after the incident. She came in at her usual time, in her usual way, early, quiet, systematic. She checked the overnight notes. She reviewed her patient assignments, which now reflected her actual qualifications rather than the default new arrival allocation. She began her rounds. Dibble greeted her by her rank and name. So did I. Chen did. The junior staff followed with varying degrees of directness, but they followed. She thanked us collectively and briefly and turned back to her work. She did not expand into the space the correction had created. She did not become warmer or more accessible or socially different in any perceptible way. She was exactly who she had been from the first morning she had walked into the ward and been handed the lightest assignments and called rookie in tones that were not meant to encourage. That was, I found, the most clarifying thing about all of it. The treatment she had received had not made her smaller, and its correction did not make her larger. She had a fixed size that was entirely her own and had never been altered by either the dismissal or its aftermath. That is not something that can be taught. It is something that has to be arrived at through a particular kind of accumulation in places most people in that ward had never been and would never fully understand. 3 months later, the ward had changed in the ways that institutions change when something has happened that cannot be fully absorbed and so is slowly, incompletely integrated. The team meetings were different, more careful, less hierarchical in the reflexive sense, with a new pattern of listening that had not existed before. It was not uniform and it was not complete, and there were still moments where the old patterns tried to reassert themselves, because old patterns are patient and institutions are slow. But there were also moments that had not existed before. Moments where a new observation was received on its own terms rather than filtered first through the rank or the history of the person making it. Moments where the question being asked in a room was what is accurate rather than who said it. Small, functional moments that would not make any account of what had happened, but that accumulated into something that was at least closer to right than what had been there before. Osai's assignment ended on schedule. She left when the rotation completed. There was no ceremony, no gathering, no formal send-off. There was a notification in the administrative system that her assignment had concluded and her transfer orders had been processed. She signed out with the logistics office and her file was closed. I saw her in the corridor on her last morning. She had her gear. She was on her way out. I said her name and she turned and I said that what she had done in this place, all of it, not just the incident but the 4 weeks before it, had mattered and that I was sorry the reception had been what it was. She looked at me. She said she appreciated that. She said she hoped the ward would be different going forward. She said it without expectation or demand, as a statement about what she would like to be true, held lightly, without attachment to whether it would be. Then she turned and walked down the corridor toward the exit. I watched her go and thought about all the things she had never needed us to know. The door closed behind her. The ward went on.